start of a new academic year. I know it's going to be a very unique one already. And Mike, Dr. Green is going to be kicking off this year's Health Services and Policy Research Rounds. And so his work really is an excellent example of the work that's being conducted here through the Institute in partnerships with the Chiefs of Ontario and with a number of Queen's ICS scientists, analysts, and research supports. So thank you, Mike, for presenting today. And just to remind everyone that the rounds are the second Tuesday of every month at noon. So this one comes really early in the month this year, just the way September sits. And again, as I mentioned, they're going to be recorded and posted on the Institute's YouTube channel. And just a little teaser for next month, Dr. Susan Phillips and Patty Groom are going to be presenting their research that they conducted over the summer called Measuring the Duration of SARS-CoV-2 Shedding Across Ontario and looking at the implications to health services and policy. And then we'll be followed by Dr. Jane Philpott in the month of November. So Mike, I'm going to hand it over to you.
Okay, great, thanks. Can maybe Elliot, can you give me a thumbs up if you can hear me all right? All right.
Can you boil some water for me?
Thanks everybody. So I'm going to talk about this project that we did over several years on First Nations and diabetes in Ontario in partnership with Chiefs of Ontario and presenting on behalf of our project team. Just going to run through a few things. So just as we're going through, what I decided to do in talking about this was the first part of the talk, I'm going to talk a little bit about the partnership development and some of the work we did on kind of working together with Chiefs of Ontario around doing First Nations specific research using ICS data. And I'm going to run also through some of our highlights of our results, which there was quite a bit out of. But I also wanted to highlight that I think in Indigenous health research, sometimes it can get a bit of a reputation of, you know, taking too long or being hard to get all the kind of academic outputs out of it as well at the end. And this is, I think, a good example of what's a project where we really were able to work together with our partners to produce outputs that were both kind of report and policy oriented and also academic papers and that could come out that would be useful for kind of spreading the messages that we had in our research more broadly. So just want to say thanks. This was a huge team. So this slide has the team members on the core team, myself, Dr. Jennifer Walker from ICES North, who's the Indigenous Health Lead at ICS as co-PI. Carmen Jones is the Health Director from Chiefs of Ontario. Beju Shah is ICS Scientist and Diabetes Specialist in Toronto. Roseanne Sutherland's also with Chiefs of Ontario. She was our embedded project advisor. Kristen Jacqueline is an anthropologist who was originally was at NAWSM when the project started, now is just south of the border. And then a lot of this work was done out of here at ICS Queens, and Elliot, Morgan, and Sharir all played important roles. And this was really a pan-ICIS effort. So I just note that for ICS, we had people from pretty much almost all of the ICS sites and different programs involved at one point or another. And really do want to thank both our stakeholder group at Chiefs of Ontario and the patient advisory group and our elder, who were really important for this all the way through. So the focus of this was to look at healthcare experiences and diabetes outcomes for First Nations people in Ontario. We did a big ICES report and series of papers to go with it, and really wanted to focus on what we could learn about policy, access to healthcare, looking for any evidence of that could point to either institutionalized barriers to care. And diabetes was a top research priority for First Nations communities. Get asked a lot about how this started, and it actually started with me getting in touch with Chiefs of Ontario, who I'd worked with before, and saying, okay, there's a funding opportunity that has an emphasis on First Nations. Is there a project you'd like to pursue? And so this was on their priority list, and so we worked together on developing the letter of intent and the application. In summary, we used administrative data from the Indian registry system and qualitative data as well to add context to this story. And we helped to actually develop the First Nation Data Governance Committee as a part of this project. It was a new idea and structure that Chiefs of Ontario and ICS were trying to implement. And so we used this project as a way of helping to get it up and going and give a real project for the group to have a test run through. Like all SPORE-related work, this is funded by the Ontario SPORE Support Unit. Patient engagement is super important, and we had a great patient advisory group that worked with us all the way through. So I do want to specifically thank all the members of our patient advisory group: Mike McKay, Karen Lauren, Tammy Shaw, Leslie Sue, Lorraine Cook, Mary Pheasant, and Shirley Williams. Their advice and really linking what we were seeing in the data to their day-to-day lived experience on the ground, and coming from so many different First Nations contexts across Ontario, the north, the south, urban, remote, and their experience with caring for diabetes, either themselves or for family members, really was very useful. We had engagement not just with patients, but so many levels of having to engage in this project, both with Chiefs of Ontario as a kind of institutional partner, as an umbrella group to represent the majority of the First Nations in Ontario, engagement with the other Ontario SPORE Support Unit entities and getting expertise from them. Their logos are all along the bottom there. And then our specific First Nations communities that we're doing qualitative work with, and our patient advisory group. And all of this for First Nations research, taking into account OCAP, which is ownership, control, access, and possession, an acronym related to data ownership to ensure appropriate First Nations leadership and governance over that. And we actually were able to, as part of the Ontario SPORE Support Unit, patient engagement had a special CMAJ supplement in 2018, where if you're interested in the engagement part of our work, there's a paper that Jennifer and Carmen really led with one of our graduate students. The data governance process is new, and so this is something that will be of interest to any ICS staff or faculty who are interested in working with First Nations data. This is now up and running for people who are interested in doing work with First Nation specific data. I would also say this is like a minimum sort of review and engagement. I think applications that are successful in this process will be ones where there has already been more engagement of the research team with appropriate First Nations partners before it comes to the committee. But the process works like this. You want to use First Nations data, particularly if you want to be able to use the Indian register system, which identifies individuals residing in Ontario who have First Nation status according to the federal government. That application is reviewed by the chair to make sure that it's complete, and then it goes to this data governance committee. The data governance committee reviews the application and either will decline it, in which case they either suggest the applicants resubmit, or they just say maybe not. There's an appeal process if needed. If they recommend that it goes forward, it goes to the Chiefs of Ontario Health Coordination Unit, which is a body that brings together the health directors from all of the First Nations for final approval. And then if the project is approved, it goes on where you can get access to the IRS data. The methods that we use for this, we have our standard ICS data. The Chiefs of Ontario data is both the Indian Register system, and then the regional health system, which is an on-reserve First Nations specific survey, similar to but not identical to the Canadian Community Health Survey. And then we have all the standard ICS data sets, and the linkage between these lets us do the work that we were interested in. I'm going to go to the next slide.
I'm not sure I understand.
All right, so at the end of that, we came out with our report on First Nations and diabetes in Ontario. It was published in November, end of November 2019. Just before the whole world changed with the COVID, we were still meeting face-to-face and working on this right up until the very end of our kind of standard approach to things, since before we revised everything. And I'll just take you through some of the main parts. One of the interesting things with this was that our First Nations partners really wanted to make sure that their story held together. So, you know, the ICS report is great, keeps everything together, but it's not very user-friendly for researchers who have a specific area of interest, doesn't bring in as much of the discussion and context as you would in a traditional academic publication. And so there was a bit of a tension between the, you know, needing to keep the story whole and the academic side wanting to get the message out in formats that are accessible to other researchers. And so we worked with CMAJ to put all of our papers together in a series so that we could have one place with some links between the papers that people could go so that they could hear the whole story if they were looking for it, rather than just individual pieces if we published in, you know, whichever journal we just thought would be best to send to for each individual paper. So the first one to be published was our paper on the general methods. And for those of you who are ICS scientists, many of this will be familiar to you, but our general approach was we used annual cohorts from April to March of each fiscal year, from 1995 through to 2015. We made use of the Registered Persons Database, prior diagnosis of diabetes in the Ontario Diabetes Database, healthcare use within the last 7 years, and alive at the start of the year, and less than 105 as just a quality check at the top end to be eligible to come into the cohort. We then looked at who had First Nation status from the Indian Register. We also looked at the rurality. So this is never perfect because it's the rurality according to your health card address, using the Rurality Index of Ontario scores for urban, semi-urban, rural, and then no score is mostly remote, not 100%, but mostly remote. So that's how we treated that. And we did have to develop a new approach of determining who lived in a First Nations community versus people who were living in a Ontario community outside of a designated First Nations community. And so we looked at the residence code, which is only available for patients who have an encounter either with an emergency department or with a hospital admission, but it's updated more often than postal code in the with your OHIP card. And then we used the persons database for, there's some feedback there from somewhere. And then there's a postal code from the RPDB when that was not available. And we also looked at comorbidities using the Johns Hopkins adjusted diagnosis groups with 3 categories of low, medium, and high. And we use that for every single one of the chapters and papers. And I'm going to go through the papers in kind of an order. We were able to do a lot of interesting work around this, looking at the whole scope of First Nations diabetes. So Laura Rosella and her team in Toronto, who have an interest in kind of risk prediction, did some work using the regional health survey to look at characterizing the risk for future development of type 2 diabetes. And so we were able to look at things like food security, body mass index, physical activity levels, smoking status, traditional food use, knowledge of First Nations language, to really get beyond the kind of standard data set that you would have available in ICS to look at that, and then do some modeling around diabetes risk. And this will then help for kind of planning down the road about what future levels of diabetes and what sort of services might be needed within communities. The next couple papers I'm going to talk about are really about the standard epidemiology, kind of prevalence, incidence, and mortality. So this paper on the overall incidence in adults was published in CMAJ in February, and kind of highlights kind of what you can learn even about policy things and where you might go even from this sort of data. So the two slides, the two graphs that are on this slide, the one at the top, the red line is the prevalence of diabetes in Ontario, and this is age, sex standardized. The blue line is the overall rate for First Nations people in Ontario, and then that's subdivided going back to 2001 into that kind of pale green one, which is status First Nations people who reside outside of a First Nations community, and the orange one is residing inside a First Nations community. And then the graph below is the same sort of thing, but for incidence. And what was some of these stories are good news, bad news. What was really great to see about this was that, in fact, incidence has been declining in the adult population overall since approximately 2005. And you can see that there's this slow slope down here for First Nations people, and you can see it flattening of the curve at the top, which was great. We interestingly, though, looking at the age distribution, it really made us think we have to start really thinking about younger adults and the importance of the time of diagnosis. So this next slide, also from the same paper, the top figure is the lifetime risk of developing diabetes. And so if you look at this thing, the age in years is along the bottom, and the graph goes up as people start to become diagnosed with diabetes. And you'll see that these two curves are already separating even before age 20. You can't see them very well because the numbers are low, but they're already starting to separate way down here. And certainly by the time you're 35 to 40, there's a substantial gap, and that gap persists through to end of life. The other good news story we found, though, is that there has been an improvement in mortality rate. This is all-cause standardized mortality for people with diabetes. The red line is everybody, other people in Ontario, and again, the same. The other lines there are for First Nations people inside or outside of communities and overall. So that got us interested also in kids. So the next paper, just to highlight, was our work on prevalence and incidence and outcomes for First Nations children. So now this was starting to look at what's going on in the pediatric groups. And this was not having the same sort of a good news story. So this is the importance of not just using single population data, but getting down into different subgroups by age. So you can see on this side over here to the far edge of the side is the prevalence, and the one next to it is incidence. The top boxes are overall for all children, and then the next two are for girls and boys separately. And what you can see is that for all kids in Ontario, the rates of diabetes are rising, both prevalence and incidence, but they're rising faster and at higher levels for First Nations children. So that really brought back the question of, well, there's an area where there maybe can be some more emphasis on prevention and trying to see what's going on with that. We also know that diabetes, the risk of developing diabetes as a child or as an adult is related even to the chances that you may have had a mother who had diabetes during pregnancy. And so we did some work then starting to look at diabetes in pregnancy, and again showed that First Nations women were significantly more likely to have both pre-existing diabetes, which is the top graph there, and gestational diabetes relative to other women in Ontario. So this is really bringing us to a place of, well, what's next in terms of research? What can we learn about that? How can we do some more work on this important time in life for people to, where really, what can we do for perinatal care to maybe help reduce the chances of higher rates of diabetes down the road? Then there's all the complications of diabetes. So the next few papers that I'm going to highlight are ones that have to do with the major cardiovascular complications. This paper from CMAJ was on cardiovascular care. And what we found here is that, again, the rates of complication have been dropping over time, which is great. The green lines are for the other people in Ontario, and the blue line is for First Nations. The shaded area is the 95% confidence intervals. And what you see is that over time, there's been a reduction in both myocardial infarction, heart failure, and death from ischemic heart disease in both First Nations and the general population, which is good, but they haven't completely closed the gap. So the gap in terms of a rate of complication is still present with higher rates of complication in First Nations people at the end. But good news that things are improving. The second slide I want to share is around treatment, because there are things we can do to try and reduce the risk of those. And again, we really see that the use of medications to help reduce the risk of cardiovascular complications, particularly statins, angiotensin converting enzyme inhibitors or angiotensin receptor blockade agents, and antiplatelet agents, you can see that the rates of prescription for these medications is not different between the other people in Ontario and First Nations, with the exception of the ACE and ARB inhibitors, which it's actually higher for First Nations people. There are some differences in the use of beta blockers immediately after discharge for MI, but they're not statistically significant, as you can see from the 95% confidence interval crossing that line there. So our takeaway from that and from some of the others, which we'll show you, is that complications might develop a bit earlier, but there seems to be a lot of times in the quality metrics that we look at that fairly similar types of care in terms of appropriate prescribing and investigation. So the next paper was on kidney disease, another really important outcome. Here you can see kind of a typical survival hazard ratio sort of curve, looking at the probability of end-stage kidney disease developing. And the green line is other people in Ontario, and the blue line is First Nations people with diabetes. And again, you see earlier development of renal complications and higher rate over the course of 10 years. Peripheral artery disease, really important because particularly the risk for amputation. It's such a terrible outcome for people, really has significant disability associated with it, and is something that what we would hear from our patient advisory group and others that people are very, very concerned of when they first hear they have diabetes. And here what you can see, there has been some reduction, but not nearly as much, for example, as we're seeing in terms of cardiovascular disease or some of the other outcomes over time, and a significantly high gap between other people in Ontario and First Nations people. And you don't see the same sort of this top graph here is actually for revascularization procedures, so procedures to try and prevent amputation by opening up an artery or doing a bypass. And what you see here is, in fact, there isn't a difference in the rate of access to that, which suggests that you think if there's this much amputation, there should be more revascularization going on. So there may be some issues with access to revascularization procedures. And this is important probably because it's not just your diabetes control that's important for amputations, but it's also access to things like foot care and other programs like that are really important to help prevent amputations. And we know that access to those services in communities is sometimes not really there or difficult for people to get to. So I think this is the last one of my the papers on complications. This was on stroke and transient ischemic attack. And again, it shows that things have been improving over the past 20 years. And you can see, though, however, the rates still remain a little bit higher for First Nations people than other people in Ontario over time. And interestingly, again, on this, a lot of the markers of quality of care in terms of access to interventional therapies or neuroimaging, once you accounted for rurality and the difficulties in people getting access to care just because of remoteness, were actually fairly similar. Oh, I lied. There was one more. I forgot. There's an eye disease, another important complication for diabetes. So Rob Campbell from ICS Queens here worked on this one with us, and you can see that overall this top one is who's had to receive treatment for diabetic retinopathy. Unfortunately, there's not good tracking of just when people are diagnosed with it, so you're sort of stuck waiting to see who's actually required treatment for it, rather than being able to look more proactively at the early identification of it. What you see here is that this is treatment. This group here, you see the higher rates of treatment for eye disease for First Nations compared to the general population. And the top one is just testing who had an eye exam. And there you see that there's actually lower rates of testing for First Nations people, so an access issue. For health service use, we also wanted to look at, are there major issues with accessing care? And the short answer is there are significant differences. For patients with diabetes, the patients who were First Nations were less likely to have a regular family physician than other people in Ontario, at 85% compared to around almost 98%. And they were also had lower continuity of care and less likely to receive care from an endocrinologist, a general internist. And as a result, most likely of not having that sort of care, the marker of admission for conditions that care in the community is likely to be able to present, show that they were twice as likely to be admitted for ambulatory care sensitive conditions, and twice as likely to have emergency department visits for acute high or low blood sugar. So definitely some markers there that access to care is a policy issue that needs to be addressed. The final paper was really around trying to think a little bit about the monitoring, treatment, and control of blood sugars. This was just published in August, the final paper in our series. And this is important because we know that your glycated hemoglobin or hemoglobin A1C level is highly predictive of the chance of developing complications. And we saw from the other papers that complication rates were higher for First Nations. And so one of the questions is, well, why? And one of the possible explanations is not good blood sugar control, which could occur for a number of different reasons. And so before you can find out what blood pressure pressure control is like, what blood sugar control is like, you have to monitor for it. So these are age and sex specific longitudinal analyses of who had the recommended number of tests for their A1C level, which is can be anywhere from 2 to 4 tests per year, as recommended for kind of guideline concordant care. We went with 2, which is the Health Quality Ontario definition of being up to date. And what you can see, first message for everybody. So that, again, the colors of these lines are the red are First Nations people who live in First Nations communities. The blue are First Nations people who live outside of First Nations community, and the yellow are other people in Ontario. And the first thing is that nobody's really getting as much testing as they should. Like the maximum test completion rate for any group, which is for other people in Ontario, is about 50% for people who are over age 65. When you get down to younger people with diabetes, the test completion rates are really very low, 25 to 30% or less. And in all of these groups, you see that for the most part, the testing lines for First Nations are lower than they are for other people in Ontario. This difference is largest in the older age groups. So there's testing, but then once you get tested, there's also control. So we took advantage of the fact that the Ontario Lab Information System, or OLIS, now is actually providing lab values into ICAHS, not just tests done, which is normally done using OHIP data. And so we were able to actually look at both the mean A1C level, the categories of A1C in terms of good, intermediate, and poor control, and the same for lipid control, because control of lipids is an important adjunct in care of diabetes, since the complications are all vascular. And what we saw here was really very important from a policy perspective, because it shows that there is significant room to make improvements to A1C control that has the potential to have an important and meaningful impact on the rates of complications. You see that for other people in Ontario, the mean A1C is 7, which is pretty close to the target of good control of 7%. Whereas for First Nations people, it was 7.59. And there was a difference with these numbers being higher if you're a First Nations person living inside a First Nations community. And when you look at how that breaks down in terms of good, intermediate, and poor control, about 48% of First Nations people with good control, compared to almost 60% for other people in Ontario. And in the very high A1C levels of poor control, almost 25% for First Nations people, compared to just under 13% for other people in Ontario. Interestingly, it was the reverse actually for lipids. So First Nations people actually had better lipid control than people in the rest of Ontario. So what were our messaging that came out away from that? The priority areas for improvement really need to be early. Seeing the increased rates early on in children and young adults, the access issues with primary and early secondary care, and we were hearing this as well from our patient advisory committee and the qualitative work we were doing, that the data we are seeing is consistent with the stories that we hear from people about their ability to access care and the importance of them being able to access care locally and in their community. Emphasis on control of A1C early on, both through monitoring and efforts to get that under control. And I didn't present the slides, but it's not just all about, that doesn't just mean pile on more medications. A1C control, so many things that go into influencing that, including access to like good healthy food, access to recreational opportunities for activity, stress drives up A1C, and we did do an analysis of use of medications and found, in fact, that First Nations people were less likely to be on no medications and more likely to be on insulin than other people in Ontario. So we weren't able to do a sort of study to prove that this was inappropriate or being used more or just related to the level of control, but really suggests to me that the answer to achieving control is going to probably lie maybe outside of the prescribing realm and more into those area of some of those other key determinants. We also saw that early screening for complications would be important, particularly since they were starting earlier and at younger ages for First Nations patients, and that this issue of addressing the barriers to success, because if people are not set up to be able to effectively do self-care for their diabetes, which is the key to it, and have, as noted, access to supports for mental health, good housing, healthy food, all of those sorts of issues, as well as access to culturally safe care locally in their community, it's going to be difficult to really make progress on those improved blood sugar control that I think is going to has major potential to make a difference for outcomes in the long run. So that's my last slide. I want to say a huge thank you to everybody on the team, but in particular to Chiefs of Ontario, again, and our patient advisory group, because they were just so central to the work that we did. So I will stop there and see if there's questions from the chat.
Thanks very much, Mike. Impressive in scope and number of partnerships. I'm sure there's a number of questions both in terms of the process of the work and the impact. I'll just let everyone put their questions either in the chat and I can moderate, or you can ask Mike directly. Don't be shy here. I don't know if people have questions in terms of even the process. I know that Mike was talking about, just in terms of the extent and nature of the collaborations and getting this type of work started and going. Well, Mike, it doesn't sound like there's...
Everybody's eating probably. Lunchtime.
Yeah, well, you've covered such a lot of ground, and we've recorded the presentation, and as well, the nice thing about the recording is that there's links to all of the papers as well. So Mike, I just wanted to say thanks for kicking off the fall rounds, and just a reminder that next month, Dr. Susan Phillips and
Joan has a question. She's waving her hand.
Oh, Joan, sorry.
Mike, that was just outstanding. I think the reason we're all sitting back saying, wow, at least I am. My question, and it's because I don't understand the process. When First Nations people live on reserve and they receive care, do they receive care from a physician that bills OHIP, or I thought their services were covered by the federal body?
So great question. You may have noticed we didn't use the term reserve through the presentation. That's because we used, when we were saying in First Nations communities, that's the preferred terminology after discussion with our partners at Chiefs of Ontario. So where we were presenting First Nations communities and outside, that some people might refer to that as on or off reserve. You're right though about the data gaps. So some First Nations communities receive federally funded services at different levels depending on their remoteness index. And so the policy that the federal government has is that in communities where there is not access to provincial services, or where provincial services are more than a certain distance away by road, they will provide different levels of services. And those start from something called a health office, which is really just an office with a manager in it, and no care is, hardly any care or no care is provided. Then there are health centers that mainly provide some public health services, sometimes some home and community care services, but not direct primary care. And so people in those communities would be receiving their care through services that either come on into their community from outside if a physician came in, or they may go out. A lot of those communities are close to towns and cities where people would receive their care in town. And then they move up to health centers with treatment, where they provide community kind of primary care treatment inside of some sorts inside the treatments. And the highest level is nursing stations. And nursing stations provide nurse-delivered primary care as well as treatment for more acute things in different areas. So we know that that's a gap in some areas, but if a doctor goes to those communities to provide care, they bill OHIP. And if we were worried a bit about, so we know we're missing, and again, if they go to a hospital, most of the outcomes that we looked at were either hospital data or OHIP billing data. So we know that probably the data might overstate lack of access to a family doctor because of nursing care, primary care in the north. But we did a little bit of sensitivity analysis, and it's not enough to close the gap all the way. So that's, and prescriptions might be the other data question people have, because non-insured health benefits is a secondary insurer for First Nations people. So the way it works is that Ontario, if you're eligible for Ontario drug benefit, because you're over 65 or you're in another eligible social assistance program, then Ontario drug benefit pays for your drugs. If you're not eligible, then First Nations Inuit Health Branch pays for your drugs. And they also would be like kind of standard extended health insurance, like our, Queen's kind of drug coverage for people for drugs that aren't covered by Ontario drug benefit.
Thanks, Mike. I see there's two questions actually in the chat, and Arthur, I don't know if you want to ask it yourself, or I'm happy to read the question out.
I can ask it myself. Thank you. Thank you so much, Dr. Green, for the awesome presentation. Really appreciate that. Pretty much the things that always pop into my mind when I see research done with First Nations communities has to do with how do you build a trusting relationship with them. I've had the opportunity of working with other communities before, and the issues of trust and mistrust of researchers, academic partners is always on the table. So I was hoping you could speak a little bit to that. How did you guys, your team, navigate such issues? How did you ensure that you could build like a trusting relationship and sustain that a lot over time?
Yeah, great question, and you're right, super important. So when I did the slide on that data governance process, I kind of commented, you can't just come up with a project and plunk it in. You're probably not going to get approved unless you've done some work on building partnerships. In this case, I think it's a matter of it takes time and listening to the partners for their priorities. So I had worked years ago before this on a project using ICS data with Chiefs of Ontario, looking actually at H1N1 influenza back the last time we had a pandemic before. Out of that relationship, when there was the funding opportunity that Ontario Spore Support Unit put out, which was really for partnered research that could make an impact, I just got in touch with them, and it wasn't, we built the research question together. So I think that's really how you got to start early. And my question to them was, what would you like? A, are you interested in, do you have time now to put in a proposal? And B, if so, what area do you think would be good to focus on? And it was, they selected diabetes. We thought together that was something that was feasible that we could do, and we built it. And then the second part was, well, who should be on the team? And so we never, all that big team collaborators, they weren't all in place when we first wrote the grant proposal, but we didn't bring anybody onto the team without talking to Chiefs of Ontario, and they had the ability to say yes or no to particular partners as we were kind of coming in. So it wasn't just us saying, oh, we think this is the best person to do this particular type of analysis. We would go back to them and say, are you okay with them joining our team? And the third thing was, besides the patient advisory group, like every single meeting, they were really, it's not token representation, right? Like when we had a meeting, there was normally 3 or 4 or 5 or more, sometimes, people from Chiefs of Ontario at each of our meetings. So the investigators worked really closely with the partners all the way through. You'll notice that on all of our papers, people from Chiefs of Ontario are co-authors. And in fact, Jennifer Walker joined as a co-PI because she had just was working with them on ICES cancer data when we were talking about this, and they were like, sure, we'd like to do this project, but we'd really like Jennifer involved. And so that you know, two-way trust and working things out, I think, is what makes a difference.
Thanks, Mike. I think that's important for everyone to think about. And I know you've partnered you've had long-standing relationships that you're able to build on as well. Just see there's one other question in the chat. Elliot, you had a question about the qualitative aspects. I don't know if you want to ask that yourself or.
Sure. So I was part of the project as well, and I know Mike's focused on the quantitative aspect of it, but given the people on the call, I know there are some qualitative researchers here, and Mike, I don't know if you want to give a brief update on, I mean, that was a big part of the study as well, but it's still ongoing, and I don't know if you want to provide an update on that.
Yeah, so we did also work in parallel to this. We talked about telling the story, and so we don't have our kind of papers on the qualitative study out yet, but we worked with Chiefs of Ontario to find First Nations community partners that were interested in diabetes who wanted to be a part of the qualitative study. So we had 5 communities involved, very distinct, different environments. And our focus in that was looking at the kind of, if you think about the course of diabetes across the lifespan and across the disease spectrum, we did interviews with people who were kind of key informants around health services in the community. We also did interviews with people who had just recently been diagnosed with diabetes, with people who had just had their first complication, and with people who already had multiple complications and were kind of at the other end of the spectrum of care. And so part of our interpretation of things like our health service utilization data was based on those stories. So the idea, for example, that there's a real need to focus on getting earlier care into the community in terms of preventive care and screening and better primary care services in the community, things like foot care, that messaging is reinforced in their stories, what we see in the data. And we also saw the good news story. Part of the good news stories is we found that people with complications, for the most part, were receiving fairly comparable care to other people in Ontario once they had a complication. And that story also resonated with them in the qualitative. They'd say, yeah, it was hard for me to get my screening test, or I wasn't getting my foot care in the community, or it was hard to get that there. When people had it, they thought it was great, but there were lots of stories of barriers getting that. But they're like, oh, but then when I had my heart attack, like the hospital did a great job. The services kind of came around me at that point in my illness. And so the idea of moving earlier into the early stages of diagnosis, early control, better prevention, those sorts of things really also came out of their stories.
Does anyone have any other questions or comments on Dr. Green's work? Mike, I just have one last question, actually, just to build on the qualitative question. Are you thinking of doing a paper that not just as a qualitative paper, but might be sort of reflecting on both the quantitative and qualitative, more of an integrated paper?
Yeah, we're thinking of that. That's where we got to finish the qualitative one first, but absolutely, absolutely. That it was really interesting to do the work this way together with the different projects, lots of teams, and then also having the qualitative and the patient advisory group input into this all the way along. So I'd also say, you know, things like spore support unit funding, people might question sometimes, you know, is really all that partnering and stakeholder engagement and patient engagement, how much of a difference does it make? I'm really glad that it was required. Like it's always been required in Indigenous health research in terms of community partnership, but having it recognized by the funding agency as well and having it be built into the structure of your project from the beginning really was really useful.
That's interesting. And do you feel like having that requirement, it pushed you in ways that you hadn't in the past before, even though you had done partnered work?
Yeah, because I'd say the big difference is that it put an extra layer of that engagement into it, because I'd say traditionally with this sort of work, we might have partnered with Chiefs of Ontario, but not necessarily had a patient advisory group. And the patient advisory group discussions were really rich, and the advisors were really engaged and provided all kinds of really helpful kind of, you know, stories of what it's like to live and receive care in their communities, that really helped us think about how to present our data and where to go with our analysis.
That's excellent. Thanks. I mean, I feel like we could have another rounds just on, you know, how to really meaningfully engage patients in research, and it gets me thinking about what that could look like. So looks like there's no other questions in the chat. And Mike, I just want to say thank you on behalf of the Institute for getting us going for the 2021 academic year. Thanks everybody.
Thanks.